Thank you very much for your kind introduction. I'm really honored to be here and participate in this very interesting session. Here are my disclosures. So let's start from some basic epidemiological data. We know that atherosclerotic renovascular disease is the most common type of renal artery stenosis, accounting for almost 90% of patients with renal artery stenosis versus 10% of cases that are due to fibromuscular dysplasia or other more rare causes. And ARVD is rather a common disease. Here you can see the results of a study in the general population, suggesting that the prevalence of renal artery stenosis is about 7% in patients with an age higher than 65 years. And among hypertensive, the prevalence might be as far as 1% of those with mild hypertension, but this rate increases and may be as high as 30% of patients with resistant and severe hypertension. And this proportion is multiplied by the presence of several other comorbidities, such as atherosclerotic disease in other vascular beds, including coronary artery disease, peripheral artery disease, or aortic aneurysm, and most importantly, the presence of chronic kidney disease and congestive heart failure. We know that the overall prognosis of patients with atherosclerotic renovascular disease is poor. Here you can see the results of a large sample from the United States that shows that the risk for renal replacement therapy, death, and hospitalization for heart failure is markedly higher after the incident diagnosis of atherosclerotic renal artery stenosis when compared to the general population. And the results are similar for our patients, for patients with CKD. Pre-dialysis chronic kidney disease patients have 1.5 higher time risk for mortality, and those on dialysis have a 3.3 higher mortality risk than patients with another cause for the CKD. Of importance, the prognosis of atherosclerotic renovascular disease depends on the underlying clinical presentation, and we have some patients with high-risk phenotypes, those with flash pulmonary edema, rapidly declined kidney function, and resistant hypertension that preserve a markedly increased cardiovascular risk compared to the other patients with low-risk presentations. As for pathophysiology, there are two different models that have been described. In the first one, the one clip to kidney hypertension, we know that there is a unilateral renal artery stenosis, and the ischemic kidney secretes renin and activation of the renin-angiotensin system, and leads to an increase in blood pressure that is renin-dependent, as the contralateral kidney, the normal kidney, can increase the sodium excretion from normal pressure natriuresis. And the second one, the one clip, one kidney hypertension, in which we have a bilateral stenosis or stenosis in a solitary kidney, in which we have again the activation of these systems, but this time we have an impaired sodium and water excretion, and the increase in blood pressure is not renin, but it's volume dependent. There are 2 points that we should remember, and this should be highlighted. First is the importance of the grade of the stenosis. We know from physiology that only lumen stenosis higher than 70 to 80% are functional and will cause a reduction of the renal blood flow and renal perfusion, and stenosis of renal debris are suggested to have minimal hemodynamic effects due to due to the presence of compensatory mechanisms of the renal autoregulation. And the second one is the importance of time, as the prolonged exposure to the high blood pressure and levels of angiotensin II causes arteriolar damage and glomerulosclerosis in both kidneys. And there are different mechanisms that may be responsible for this observation, as the loss of renal perfusion leads to ischemic nephropathy, microvascular air function, increased oxidative stress injury, and infiltration by inflammatory cells, which in turn results in kidney fibrosis and irreversible kidney injury. So, let's move on diagnosis. We know that patients with atherosclerotic renovascular disease may present with multiple clinical manifestations, ranging from asymptomatic disease to severe presentations, including flash pulmonary edema, rapid kidney function decline, or resistant hypertension. You can see here in the table the most common ones: sudden onset or worsening of existing hypertension, grade 3 severe hypertension, resistant hypertension, or atrophic kidney, or a difference in the size of the kidneys higher than 1.5 centimeters, unexplained rapid kidney function decline, decline after the starting treatment of an ACE of an ARB agent, increased albuminuria or proteinuria due hypertensive damage in the normal non-stenotic kidney. And finally, we should not forget that the repeated hospital admissions for acute decompensated heart failure and the presence of unexplained flash pulmonary edema should prompt further examination for the presence of atherosclerotic renovascular disease. And we have several available imaging modalities in order to diagnose these patients, each one with different strengths and limitations. So we have the duplex ultrasound, which is frequently used for screening as it is non-invasive and it's inexpensive, but CTA and MRA are more reliable for diagnosing these patients with their specificity and specificity rates being significantly improved over the past years and reaching up to 90%. Or 95 for the MRA. However, despite these improvements, the diagnostic accuracy of CTA and MRA, the improvements in this accuracy, catheter angiography is considered the gold standard method, as it enables the measurement of intervention gradients and can help us characterize the stenosis, and also we can evaluate and treat in the same time. So, by consensus of experts, a functional, a severe renal artery stenosis is considered the lumen stenosis higher of 70%, and the moderately severe stenosis of 50 to 70%, and the presence of hemodynamic severity as confirmed by the high translesional gradient of higher than 20 millimeters per mercury. And let's move on the management, which is a controversial issue for more than 20 years. And you see here, this is from a commentary from our group, the historical timeline for the different practice patterns in the management of atherosclerotic renovascular disease, and the associations with different published randomized clinical trials, and the recommendation changes all the time, and the medical community being divided on whether we should or we should not revascularize patients with atherosclerotic renovascular disease. So, standard medical therapy should be offered to all patients with atherosclerotic RAS and should aim to achieve adequate blood pressure control, with multiple drug regimens should be used, and we should use ACEs or ARBs inhibitors as a first choice, as we have strong data from observational studies that these agents reduce mortality. In addition, we should mention the role of other treatment strategies to decrease the cardiovascular risk of these populations, including statins, antiplatelets, smoking cessation, exercise, and of course the weight loss. So, as for the revascularization, these are the first studies before 30 years that showed that revascularization was effective in terms of decreasing blood pressure. You see here, systolic blood pressure decreases up to almost 30 millimeters per mercury, and also it is very effective in stabilization or even improvement of the kidney function. However, in the later years, we have the first randomized trials that attempted to test the superiority of revascularization versus the standard medical therapy, but the results were not the same. Here you can see the first studies with blood pressure endpoint that show that although PTRA, the revascularization, was associated with a decrease in the antihypertensive drug used, we have no differences in the mean blood pressure levels. And these results were the same with the later large randomized trials with more harsh endpoints on renal and cardiovascular events that showed that the revascularization had no additional benefit on renal function, adverse renal events, and cardiovascular events when this compared to standard medical treatment alone. However, all these studies met severe criticism due to a number of limitations in study design, methodology, and the execution. And in brief, we should mention that they used non-standardized criteria. You see here a characteristic example, the Astral trial, in which they define patients with substantial ARAS. They did not report the degree of the stenosis, and they include patients for revascularization if the doctor were uncertain if the patients would definitely have a clinical benefit from revascularization. Other disadvantages include the low event rates. They had no criteria relevant to the time of the stenosis, and also they had high crossover rates between the treatment arms. Up to 50% of patients in some of these trials went from the non-active group to the active group during the trial. In addition, they characterized by large enrollment delays, and they needed to have severe protocol revisions during the execution of the trial. Here you can see the CORAL study, which included at first patients with severe renal artery stenosis and resistant hypertension, and they mentioned that the renal artery stenosis should be defined with invasive catheter angiography as stenosis of higher than 80%, or as stenosis with 60 to 80%, and an increased systolic pressure gradient. But during the trial, and due to enrollment delays, the threshold of blood pressure level was not longer specified, and patients could be enrolled in the trial if they have CKD with eGFR levels lower than 60 ml per minute, and the diagnosis of renal artery stenosis could also be identified with the use of duplex ultrasonography, CTA, or MRA. In addition, they had great variability between and within its study protocol in the imaging technique used. You see here the STAR study that almost 1 out of 3 patients had been falsely identified to have renal artery stenosis by the non-invasive imaging and did not have standing. And all of these disadvantages resulted in the inclusion of patients with mild and asymptomatic renal artery stenosis, with mild hypertension, with advanced CKD, and they totally excluded patients with high-risk clinical presentations suggestive of the presence of a functional renal artery stenosis, such as those with flash pulmonary edema, resistant hypertension, and rapidly declining kidney function. To this regard, we have only a few clinical trials in the literature that could examine the possible benefits of revascularization in the field of of atherosclerotic renal artery stenosis. But as you can see here, all these trials appear to have been terminated without publishing any results. So we have to go to the literature and search for a second round of properly designed observational real-world evidence that examined whether revascularization would be of benefit for patients with high-risk clinical phenotypes. Here you can see a seminal study in almost 500 patients from the United Kingdom, in which the authors stratified the patients to those with low risk and high risk clinical phenotypes, flash pulmonary edema, rapidly kidney function decline, or resistant hypertension. And although there was no difference between medical and revascularization treatment in patients with low risk clinical presentations, among those with a high-risk phenotype, revascularization was associated with lower blood pressure levels, with a better kidney function, and also with higher survival during the follow-up. In addition to these beneficial effects in survival, we have also a lot of studies suggesting that the revascularization is associated with a number of other benefits in other parameters, including the decreases in blood pressure levels. Here you can see a study in 72 patients with resistant hypertension as defined by the presence of uncontrolled hypertension using a 24-hour ABPM. You see here that revascularization was associated with a decrease in about 15 millimeters per mercury for the systolic and almost 10 millimeters per mercury for the diastolic blood pressure, and also with a decrease in the number of antihypertensive medication used without any effect in the kidney function. As for those with heart failure, we have several reports suggesting that revascularization is associated with a lower risk for hospitalization for heart failure. Either these patients had a past history of acute decompensated heart failure or no, and also there are several reports reporting that revascularization is associated with an improvement in the total NIHA score of these patients. Finally, and I'm sure that most of this audience know that patients with rapid kidney function decline may benefit from revascularization, and this has been showed by several small studies, by case reports and case series. And this is an important addition to the literature. This is a sub-analysis from the CORAL trial, which showed that in patients that presented an increase in kidney function after the revascularization, this proportion was higher in patients that had renal artery stenting during the trial, and among those patients that had improved kidney function after the revascularization, these had a lower risk for death and also different and multiple cardiovascular and renal complications. So all this data led to a significant shift in the recent recommendations, and we have a lot of reports during the last year from the KDIGO, from the American Heart Association, and during the last 6 months for the ERA and the ESH societies that suggest a personalized approach in order to select the patients who will benefit from revascularization, and we have strong indications all patients with high-grade stenosis, higher than 70% of the lumen, with the coexistence of one of the following criteria: resistant hypertension, new onset or uncontrolled hypertension, the presence of acute decompensated heart failure, rapid decline of kidney function, the intolerance of an ACE or an ARB, that is the decrease in GFR levels higher than 30% after the initiation of these agents, or the coexistence of renal replacement treatment if the stenosis is detected shorter than 3 months of the initiation of the dialysis, or if uncontrolled hypertension with more than 5 drugs is present. In addition, acute kidney injury due to occlusion or high-grade stenosis. And finally, we should not forget that all patients, that all kidney transplant recipients with renal artery stenosis should be revascularized. We have also some moderate indications, patients with high-grade stenosis, higher than 70%, with the presence of chronic heart failure, or with the presence of that are asymptomatic that they have bilateral stenosis or stenosis in a solitary kidney, but with viable kidney parenchyma. And the same indications are also reported in the latest 2023 ESH guidelines. And at last but not least, we should highlight that in addition to these indications, we should also perform a very careful evaluation of the possible kidney viability of the stenotic kidney in candidates that are going to be revascularized, and detect those that are more likely to benefit from this procedure, and they include the RAS degree higher than 70%, the kidney length higher than 8 centimeters, a renal resistive index in the renal duplex lower than 0.8, and the maintenance of the corticomedullary differentiation. So in conclusion, atherosclerotic renovascular disease is a common clinical problem, and the presentations may be relevant to different specialties, and they have an important prognostic association. The major randomized clinical trials in the field included patients with atherosclerotic renovascular disease of different degrees and not patients with high-risk phenotypes. And we have several pieces of observational data that clearly suggest that revascularization is associated with future renal and cardiovascular benefits in patients with high-risk phenotypes. And all this evidence resulted in a shift in the relevant recommendations, with the recent suggestions supporting that revascularizations should be offered in selected patients with high-risk phenotypes, of course, after careful evaluations. Thank you very much for your attention.